Well, thank you very much. I'm happy that we could convince Ayad to do the webinar for us. I'm really happy. I appreciate the time and that you put together cases that are explaining how you're doing that you're willing to share with your colleagues best practice from the hospital, and also explain, of course, the use of Asahi products and how they work the best for you. So I'm really happy that you have taken the opportunity with us, and the stage is yours.
Thank you, Esther Thomas. Thank you for the invitation. I'm very happy to do this. Yes, let's talk about the middle meningeal artery embolization, which is becoming like a hot topic maybe in the recent years because of many indications, but I think the most common indication nowadays, which the embolization of that artery is being discussed, is the chronic subdural hematomas. But of course, it's not the only indication. It is middle meningeal artery, usually part of the treatment of the dural arteriovenous fistula. It's usually integrated in the treatment of EVMs because of recruitment of the dural stuff from the middle meningeal arteries, and it can play an important role in embolization of certain tumors. And I think the most common one is going to be the meningioma. So we can't address, of course, all the technical aspects regarding all the indications. So I will focus on the chronic subdural hematomas, and we'll share some thoughts about the other indications, but very shortly at the end. If we are gonna start with the middle meningeal artery, I think most of the discussion is gonna be around the anatomy of that vessels. So if you understand this anatomy, usually you will be safe during embolization through the middle meningeal artery. And I believe during most of the indications, especially in the case of the subdural hematoma, this embolization has to be safe. I mean, there is no procedure, of course, without complication, but the complication rate with that procedure should be really as low as possible. I wouldn't say like so there's stuff like blindness or visual symptoms after embolization. So the middle meningeal artery should be kept really with that indication maybe at 0%. So the anatomy, I will only discuss, of course, the applied anatomy, or the part of the anatomy which related to the procedures which we do. The artery usually enters through the foramen spinosum, doing that typical curve, and after that dividing into the primary branches. And just at that level, after passing through the base of the skull, starting from that point, we're gonna discuss a lot of variants, including that artery. But the most relevant things is gonna be like this. We have the primary branches from the middle meningeal artery, and these primary branches is not like fixed in all patients. I would say in every other patient, you're gonna see like other or different distribution than the other patient. So generally speaking, we're talking usually about the frontal branch and the parietal branch, but it's rarely to see like two separate branches like described in the books, like frontal one like here and the parietal one like here. Usually you have like it's one trunk doing the frontal and parietal branch, and the other one's gonna be the petrosquamosal branch. And the another patient, you got like a typical frontal branch and the typical parietal branches. And this is the main two branches, like the biggest primary branches. But going through the foramen spinosum, usually the middle meningeal artery doing or giving a very important branches, which is unfortunately couldn't be or can't be seen in most of the patients. So going through that foramen here, or that curve on the sagittal view, you see usually that the middle meningeal artery giving one or two branches. So most of the patient you won't be able to see anything, but sometimes you see, and if you're gonna see anything, it's gonna be on the coronal view, not on the sagittal view. And the two important branches at that level, gonna be the cavernous branch and the petrous branch. And these are the two branches which you should avoid to embolize, of course, during whatever the procedure. So if you look at A and you see a branch coming from there, going especially superiorly, it's gonna be the petrous branch, but it could be, of course, the cavernous branch. And if you would like to see the branches more better. So you have to do like a dynasty, and you can delineate the vessel going through the foramen spinosum, and you see that branch taking off. And after that, you're going to see that the petrous branch going dorsally and the cavernous one is going ventrally. Now, the petrous branch, as I mentioned, it's very difficult to see. And this is important because a lot of colleagues just describe the other branch, which is a petrosquamosal branch, as a petrous branch. And this is important. Why? Because usually the petrosquamosal branch is a branch. I have to move the monitor here. It is a branch which goes through the foramen spinosum, and that is the middle meningeal artery, and give off that branch which is run along that suture, along that suture, which have the same name. So this branch, it is important to delineate this discrepancy because it's going to be this branch. And this branch is quite often involved in the dural arteriovenous fistula, especially the ones at the level of the sigmoid sinus. And usually it is safe to do the embolization to that branch. So this is not the petrous branch, which should you avoid to embolize. The important things to notice here that the two most important branch is going to be at the level of the foramen spinosum, and that's why you should avoid doing any proximal embolization through that artery to avoid these two important branches. And if we are studying the anatomy, of course, we're going to discuss the origin and the variation, including the origin of the middle meningeal artery is just huge. But I will only mention that like one of the most relevant issue. It's described as a rare entity, which is the recurrent meningeal artery branch coming from the ophthalmic artery. How rare is that? I don't know, but we see this. So if you read, it depends on the literature. It's like 0.5% to 2-3%. I think 2-3% is more realistic because we quite often see these variants. So this is, of course, important because if you got like an origin like this, it's a variation, and it is a variation inside it because sometimes or most of the time it's only the frontal branch which is gonna be like going direct from the ophthalmic artery, and the parietal branch with the other branch is gonna be coming off from the external from the IMAX. So in that case, of course, you have to examine the other branch because of the primary or outer network, you may be allowed to do the embolization from the dorsal branch and reaching the frontal branch without catheterizing the ophthalmic artery. And it's really depends on the indication if you have to do like an embolization through the ophthalmic artery. I mean, it is doable. There is a way, but you have. I think it depends very hardly on the indication because, of course, if you are going to the ophthalmic artery, whatever you're going to inject, it's going to be significant risk losing some stuff proximally. And the other important anatomical aspect is going to be the anastomosis between, of course, the middle meningeal artery and the ophthalmic artery. And there are too many variants, I think, described, but the most important one is the meningolacrimal or meningo-ophthalmic variants, where the branch from the ophthalmic artery, usually the sphenoid branch, is doing like one branch doing the entire ophthalmic artery, like you see here in that case, or sometimes it's only the lacrimal branch, which is going to be the meningolacrimal variants. Why is this important? It's important because of course, to avoid the embolization of the ophthalmic artery, but it's a very interesting landmark. So the first thing is you have to take care of. If you look on the coronal view and you see during the angiography of the external carotid artery, any vessel going through the orbita, so these vessels could be inside the orbita. And usually it's whether the occipital artery, which is definitely on the sagittal view to see it completely outside the orbita, or it's going to be one of these variants. So this is the first point. And the second point is, this case you see is like obviously that the ophthalmic artery coming off the external carotid artery, but it's not always the case, because here is a very interesting case where you see actually that you don't see any ophthalmic artery and you don't see very clearly the variant. But if you look in details, you see something here. This case was done with my boss, and he saw that a small connection there, and you expect that because of the anatomy, it's gonna be like a branch coming from the siphonos branch, and after like going inside, put some coils in the branch and doing another angiogram, you see clearly the connection to the ophthalmic artery. So this anastomosis is there. It could be there even if you don't see it very well. I would say you have to search for that anastomosis to be sure that's not there. Otherwise, you go like supraorbital, and you're gonna be in most of the cases, whatever which embolic agent you're gonna use, you're gonna be safe doing the embolizations. The last anatomic things, and I wrote this because we encountered this in a couple of cases, you have to look for the dural pial collaterals. And of course, I'm not talking about AVM cases here, but this patient was only with a stenosis of the internal carotid artery. Apparently, he got like an old infarction, which we couldn't see in the MRI. But because of that, you see some collaterals from the middle meningeal artery doing very small MCA branches. So you have to take care about this. You have to know these things could happen, and you have to search for it to avoid, of course, embolizing these normal branches. The other important anatomical stuff is actually the dural vascular anatomy itself. And in that regard, I can really recommend this review from Maxim Shapiro, because he puts a lot of very nice pictures describing the dural and the level of the dura. And I found this especially interesting because if you look at the dura and all the three layers of the dura, like the periosteal layer and the meningeal and of course the basal layer, if you look at the periosteal layer, which is the first layer, there are the primary vessels, the primary branches of the MMAE, maybe the primary the outer network, which you see that the size is about 100 micrometer. But we are going inside, reaching that deep layer, you reach the capillary, which was very, very, very tiny. And the speaking about the subdural hematoma, or maybe because it's inside this layer, it could be like an intradural hematoma. It's happening at this level. We are talking about leakage from that capillary layer. So you have to think about that when you're choosing your embolizing agent, that this is your goal. Maybe you don't have to reach this layer with your embolic agent. I think it's not possible, but the aim is to reduce the flow to that layer. And this is completely different if we are speaking about like dural fistula, because all the dural fistula vessels, or AVM, we are talking about the vessels which is a very periosteal layer, which is much more larger, and it has, of course, some implication on deciding the embolization material and the position of the microcatheter. I will address this shortly at the end. That was like the anatomical part. And going to the practical part. So subdural hematoma, I think if we talk to the colleagues and in each congress, usually there are a lot of variations about the material which everyone would like to use and which embolic agent to use. So far, there is no clear consensus, and I think that all or most of the studies which have been done so far, even randomized trial, meta-analysis, or some retrospective studies, there is no very clear preference in favor of one embolic agent of the other, or which microcatheter to use, or which position, and all of these stuff. But so here, how we do this, okay? And I'm saying this because, of course, you can use another material, you can use a different embolic agents. I think at the end, it's gonna be the personal preference of each physician. Usually we do it with a 7 French sheath. Why? Because we would like to have the ability to have more than one microcatheter only if we need to. Because usually we don't need to while treating subdural hematoma, but if we need to, so we would like a larger sheath. The second point is most of the patients which we treat with subdural hematoma are really old patients. So the access to that patient sometimes could be very challenging. And if you got like a larger catheter, usually you will be able to navigate it easily. Which catheter do we use? I think you can use anything which gonna be stable. If you are talking about subdural hematoma, whether it's Fubuki, Envoy XP, which is more stable. And usually we use the Echelon microcatheter for doing this. Could you take larger microcatheter doing this? I heard from some colleagues which use like 27 microcatheter doing that, aiming for wedge and injecting some liquid embolic. Think you can do this. we do it like with an echelon, and we try extra to avoid having a wedge position actually, because most of the time we work with the microparticles. Which wire are we going to use? We usually use the CHIKAI or the Traxxas, navigating the echelon or the headway or another microcatheter inside. So bringing the microcatheter, you have to decide at which position. And I think the position of microcatheter, it always or it usually depends on how you're going to embolize this with which embolic agent. I mentioned we use microparticles. So our position usually at the top, as I mentioned, usually we try to be supraorbital in that branch selectively and doing the embolization, and after that doing to the other branch selectively with the same microcatheter and doing another embolization. And of course, we try to avoid like a wedge, because with particles like this, you can doing more with the flow going to into the periphery. Which microparticles which we use? Usually we use the 100 to 300. Excuse me, but you can use, of course, MBCA, histoacryl, and I read a lot of paper with that, and I think it's not a bad idea doing this. You can, of course, using Onyx, and there's a study doing with Onyx showing that the recurrence rate is indeed fewer than the without an MMA embolization. I think you can use whatever you want. We think that using the microparticles, we would reach a diffusion very deep and deep enough or distal enough, allowing us to have a stable results at the follow-up. At the same time, we don't sacrifice the middle meningeal artery, which you don't know we may need in the future. And I saw indeed a couple of cases after subdural hematoma with dural arteriovenous fistula, where the middle meningeal artery was a route for embolization. But you can use anything. Could you use coils? I think there is no study for this. I personally wouldn't prefer using coils because of the anatomy which we mentioned. We try to reduce the flow to the very distal capillary layer, which we can't even see. If you use coils, you're gonna induce like a proximal occlusion, and a dural is there is a lot of networks, like a primary network and a secondary network, and the collaterals from the other sides, the transcranial collaterals from the superficial tumoral arteries. So I don't know how come if you occlude this proximally with coils, you're gonna reach a very stable results. I heard a lot of colleagues using that, and they are satisfied with the results. I think that's something we have to prove during any study. Because I saw like the two variants, like colleagues talking about that, having very stable results with coil and proximal. And I heard about other cases where the colleagues were able to inject even particles through the coils. So I don't know how good gonna be the coils occluding the MMA proximally. Regarding which embolic agents or the main differences, I would really recommend this paper. It's very well written and describe like the main differences between different liquid embolic agents, especially between onyx, squid, and fill. I think it's very important because they are more or less belong to the same family. We use, as I mentioned, the microparticles, impospheres, and usually the size is going to be 100, 300. You can take a little bit larger if you're afraid of some anastomosis or distal penetration, but usually that is the particles which we use. When we treat subdural hematoma, all of the time we do bilateral embolizations, and we believe indeed this will reduce the recanalization rate significantly. Here's a case which we had subdural hematoma on the left side, and you see from the right side, even before embolization, the collateral is going to the other side. So in our practice, we do all of the cases bilateral embolization using the same microcatheter with particles. Yes, which follow-up? Usually we do a follow-up with CT after 4 weeks. And it depends on the situation, how it was initially. We decide if another follow-up after 3 or 6 months is usually decided. So 4 weeks is a very short period. Most of the patients come with no recurrence and very good to see brain. But still, I believe later follow-up, like in 6 months, is still mandatory just to check how good are the results. And now if we move to the other indications, so as I mentioned, we can't really discuss all the technical aspects regarding dural arterial fistula and EVM. There are very different entities, and depending on the anatomy of each disease, you're gonna decide how to embolize, how far you're gonna go inside the artery, and which embolic agent you can use. But I just want to mention some practical points which we consider very important regarding the AVM. It's a huge discussion, and if we start talking about the AVM, we won't finish this session as well. But the most important thing is, which we commonly use, if you have an AVM and you got like some parts supplied from the middle meningeal artery, just don't rush for that artery, because usually it's a very good access. You can reach the AVM, you can go very deep inside the artery, and usually this artery is considered safe for embolization. Just don't rush for the artery. Take a lot of time understanding the AVM, because of course it could be a very good option doing some embolization, of course, and sometimes it's necessary. And I can remember some cases where we got ruptured flow-related aneurysm because of the supply dural, only because of the dural supply. So you have to treat this. It could be like this, but there are a lot of examples which we consider dural embolization through the MMA is very dangerous from the AVM, because at the end it depends on the venous segmentation. So if you start doing your embolization from MMA, ending up occluding like one primary vein, you won't be able to realize this if you don't understand the anatomy, and this could end up in a catastrophe. So the only recommendation which I can shortly about this topic is, if you have an AVM with a middle meningeal artery supply, just don't rush for that artery, consider it safe, take your time and try to understand the anatomy of the AVM, and doing a lot of pictures, doing a lot of 3Ds, 6Ds, and try to do the venous segmentation. Regarding the dural arteriovenous fistula, as we mentioned that like in the dura, there are the 3 layers, and this is a completely different layer than the layer which we aim doing the subdural hematoma. I mean, it's logic, it's a different entity, and so it's different, completely different than doing embolization through for a subdural hematoma. And one of the most important implications is gonna be actually the position of the microcatheter. So it won't be only enough like going distal in the artery above the orbit and doing the embolization. I won't recommend this, and I saw some cases like this, and it's very, very, very hard and could be very risky doing the embolization like this. So if you have a dural arteriovenous fistula, you have to navigate your microcatheter reaching that very distant artery, reaching the fistula point. It's like if it is like a sinus branch coming from the middle meningeal artery to superior sagittal sinus, so you have to aim to get that point and don't accept to be very proximal. You can do definitely like little proximal embolization, but you have to control the reflex. And I would say you can't let this for like luck, how large the reflex is, but you have to control this. And one of the way to control this is do like a pressure coater technique, put some coils and glue to avoid a lot of reflux. But still, I believe to achieve a good results for the dural arteriovenous fistula, you have to navigate yourself very distal in the MMA. Usually you take the best branch for the dural fistula, and most of the times it's the MMA. So you have to be in a very good position, able to occlude everything. And I can really recommend this combination of marathon and CHIKAI X010. I learned from Achieve, and it's really amazing. So you can try other stuff definitely, but in our experience, this combination with this microcatheter and this wire, you can navigate through a lot of curves through the artery and navigate your catheter very, very distal. Do you have to take like a detachable microcatheter? Of course, you can do this, but in my experience, it's usually more difficult than the marathon to navigate there. And you don't have to care a lot about retrieving the marathon after embolization. I mean, we do a lot of pressure cooker embolization through the MMA. Still, it's really very, very rare not to be able to retrieve the marathon. Talking about this wire, actually, you have a couple of advantages using that wire, especially in the MMA. And one of the most important things is you can torque this wire very good. if you look at the MMA, especially in case of the fistula, usually you have a lot of curves with a very, very tight angulation. And the problem is going to be like you navigate through two curves, and after the third curve, you rotate like crazy on the wire, and nothing going to happen. Um, this is one of the advantages of this wire. So you can torque this wire very, very good, even through a very difficult curves. And one of the main advantages, and could be sometimes a disadvantage, is you can shape this wire very good. So if you shape the wire, give the very good curve, you will be able to do that, and it will take the very good curve, and it will keep that curve. And here start with the disadvantage that curve, it keeps the curve that good. If you want to change the curve to reshape that wire, it's usually very difficult to do that. So you have to think a lot about the shape you are giving to the wire. Otherwise, you're going to spend a lot of time playing with the wire, changing the shape. You see the wire very well, and it could be very important because in case of the large fistulas. And the hydrophilic coating of this wire is very, very important, because we work all with the different micro wires, and when we start like with the smaller micro wires doing difficult navigations, it's usually 1 or 2 times when you lose all your hydrophilic coating, and after that you're gonna realize you are not able to push your microcatheters, or the worst variant, you can't retrieve your wire from the microcatheter, which is, it's not a funny thing to have after doing a very difficult navigation. It's sometimes only because of losing the hydrophilic coating. This is one of the advantage of this wire. The second thing is about treating dural arteriovenous fistula. So for subdural hematoma, you look for stability. Difficult vessels, usually you try to be very proximal. In the external carotid artery, you don't have to navigate yourself till the IMAX, but this could be challenging during the treating the fistula, because in that cases, usually you have to be like very distal. I mean, it's logic. It's the IMAX doing another big branches, and it's a big artery. So if you navigate through a lot of curves, you're inducing a lot of pressure, you're gonna dislocate your microcatheter. So you have to get that proximal stability, but you have to get something which is still soft. You can navigate very distal inside the IMAX. So Fubuki can be interesting in that case. Otherwise, you have to use an intermediate catheter. We are not, no, we are not in our clinic, at least. We are not, I won't say big fans, but we don't use a lot of intermediate catheters, because most of the times it's not of help. We believe that you need a guiding catheter, and you need that combination of maybe stability and some flexibility to be able to navigate very distal. But still, there are some cases, indeed, you have to navigate some intermediate catheter very deep inside the MMA maybe, or the IMAX. Another advantage which I found in Fubuki, and it's only maybe relevant for dural fistula and the AVMs, of course not relevant maybe for the subdural hematoma, that the lumen, the inner lumen from the Fubuki, it's very important, because this lumen allow you to put 3 microcatheters. So you can put through microcatheter through another 7 Frenchies. But this lumen will allow you to put some things like a detachable tip catheter and magic, and maybe a marathon inside, which is usually it's not possible through other 7 French catheters. Yes, and this is regarding the Fubuki, which is the had a good hydrophilic coating. It's soft, and still proximally it's stable. So if I want to conclude that you have to respect the anatomy of that vessels, and according to the anatomy, you have to decide at which level you have to embolize, and which embolic agent you should use. You have to understand the pathology. I mean, it's logic that subdural hematoma is completely different than the other pathologies. And according to that, it is different how you gonna embolize, and how penetration, how deep you want to go inside that artery, or how superficial you want to stay. And after doing all of this, after doing your anatomic understanding, I think you can start treating the artery. Thank you so much.